Okay, hello everyone, and welcome to the National DermaSculpt webinar. It's been a while since we've done a webinar for the DermaSculpt Microcannula, so I'm really excited to reconnect with a lot of you. I'm seeing a lot of familiar names here. Can we please load the presentation? There we go. All right. I'm really pleased for you guys to join us this afternoon or evening if you're on the East Coast, wherever you may be. So I am Dr. Kian Karimi. I'm a facial plastic surgeon here in Los Angeles, California. And I've also had the pleasure of being the medical director for the DermaSculpt Microcannula for over a decade. So I want to just kind of touch base with all of you about the microcannula, and then I'm going to go through specific areas and techniques of utilizing the microcannula. So if we go to the next slide, please. So microcannulas have come a long way. So when I became a medical director in 2011, 2012, only about 10% of us were using a microcannula in any capacity. Now, microcannulas, as you may know, have been used in Europe and worldwide for many, many years, but it really wasn't until late 2009, 2010 that the first microcannula in the US, the DermaSculpt microcannula, was introduced. And many of you have heard me on podium over the last decade about my enthusiasm for the microcannula. And now in 2023, anywhere from 70 to 90% of us are utilizing a microcannula in some capacity in our practices. So you can see how it's come a long way. Next slide, please. So the DermaSculpt microcannula, again, the first microcannula introduced in the United States, has a lot of different sizes and shapes that we can use. And I'm going to go through my favorites with you for specific areas, but there's all the way as small as a 30 gauge microcannula, all the way to a 22 gauge for hyaluronic acid fillers. And for those of you that do fat grafting, there's also an 18 gauge microcannula that can be useful. Next slide, please. So this chart is a little bit outdated because we keep getting new fillers every year, but this is something I put together in terms of my preferences and suggestions. As we've gotten some thicker fillers on the market, and a lot of us are using Sculptra and Radiesse and thicker products, we've had to use larger and larger microcannulas. Now, as I'm going to share with you, the larger the microcannula that you use, the safer it is. But of course, once you start using 23 and 22 gauge microcannulas, because they're larger, it can also be more uncomfortable for your patient. So really picking the right microcannula for your product is key. You want something that's not going to be too hard to push through the microcannula. You also want a microcannula that the product's not going to come too quickly. And there are some really thin products on the market, like Volbella and Redensity, which is RHA1. And so you really need to kind of find the right microcannula for the right product. Next slide, please. So again, this is a general guideline, and a lot of you, whether you're novice, intermediate, or advanced, have kind of figured out which microcannula you like for different areas. In general, I use anywhere from 25 gauge, 1.5 inch, which is my favorite size, to 27 gauge, 1.5 inch. And then for more extensive procedures like panfacial Sculptra, or if I use micro fat grafting, I'll use the 22 gauge microcannula. For hands, I also like the 22 gauge microcannula because it's really nice to have the length of that longer microcannula to reach the entire back of the hand. Next slide, please. So what are the advantages of microcannula? Really, to me, it's about safety, which is why I first started using a microcannula. We have a lot of data now that supports that utilizing a microcannula is safer. There's a lot less chance of having an intravascular vascular occlusion, vision loss, stroke, etc. But I also love it because it allows you to use two hands. It's artistic. We all understand facial anatomy far better now than we did even a decade ago. And so getting into those deep compartments below the SMAS or above the SMAS, which is really where we want hyaluronic acid fillers, can be done really well and accurately and safely with a microcannula. Next slide, please. So again, a lot of this is very basic for you guys, but utilizing the cannula, there's less bruising, less pain in most areas that doesn't not necessarily true for all areas, really minimal downtime. I mean, when I first started my practice in 2011 here in Los Angeles, I differentiated myself from a lot of other practices by utilizing bruiseless fillers, which is a little bit of a misnomer, but definitely patients, especially for under eyes, for lips, and for areas that tend to bruise more, really enjoyed the microcannula because they didn't have that embarrassing bruise. They didn't have any social downtime. Next slide, please. So again, I'm going to be going through this on the videos, but the skin sculpting technique, as we called it, really comes down to, so the DermaSculpt microcannulas all come with the hypodermic needle, which is usually 1 or 2 gauges larger than the microcannula that's supplied. So for example, with the 25 gauge, 1.5-inch microcannula, which is my favorite, it comes with a 23 gauge hypodermic needle. And so you have that little puncture that you can use to get into the port with the microcannula. Next slide, please. So again, we've gone through this in terms of advantages. Now let's talk about the disadvantages. So there is a learning curve to utilizing a microcannula. And I've trained thousands and thousands of practitioners over the last decade or so on microcannula use. And I've noticed that for the first timers, it's a little bit intimidating, particularly when going into the deeper compartments, because you're like, where is my cannula? Where is the tip of my cannula? So again, when I show you some of the videos today, I hope to be able to demystify that for you. But it is important to have training with somebody who is proficient with microcannula. Fortunately, all of the major companies now have a microcannula indication for their fillers. So that's great because you can have these companies send a trainer to your office and learn on the microcannula. If you want to get more advanced with the microcannula, then you take other courses like the ones that I offer or that others offer to really get proficient with it. Next slide, please. So DermaSculpt Microcannula, again, I've tried every microcannula on the market, and a lot of you have as well. But the bottom line is that it has really the perfect balance of flexibility and rigidity. You don't want something too rigid because you're still going to bruise and cause issues. You don't want something too flexible either because you just won't be able to accurately inject the fillers how you want. And DermaSculpt has the widest range of sizes to really customize your injection experience. Next slide, please. It is still the #1 microcannula utilized in the United States, and people that use it and love it really have a lot of loyalty to our microcannulas. So in my journey in the microcannulas, I actually was working with the companies for many years to get an on-label indication for microcannula. And actually, it was Galderma that was the very first major US company to have a microcannula indication. I believe it was 2015 or 2016, where we finally got the microcannula approved for Restylane Silk for the lips, if you may recall. And that was really revolutionary, and I was so happy to see that. And I'm even more happy to see now that Allergan and now even Revance have microcannula indications for their fillers. Next slide, please. So in 2012, so over a decade ago, there were some studies looking at cannulas versus needles, and I used to be on all these panels and debates. Is it accurate, you know, with cannulas versus a needle? Is it as good? Do you have to use more product? There were all kinds of misconceptions about a cannula versus a needle. Most of those are pretty much gone now, but this was one of the very first studies basically showing that the aesthetic result can be just as good with a microcannula as it can with a needle. Next slide, please. And it was so amazing because the filler boom really started around this time. And it wasn't until 2015 that the FDA put out this warning and said, whoa, 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 guys, this is to the public. Fillers can cause serious problems. Most people had no idea that fillers can cause tissue death, necrosis. A lot of us injectors and physicians really didn't understand vascular occlusion a decade ago. So in 2015, the FDA came out and said, you really need to be careful with these fillers because they can cause tissue death, they can cause blindness, they can cause stroke. And again, I want to emphasize a microcannula can cause all of those things. However, the likelihood of it is far less with understanding of anatomy and with good technique. Next slide, please. So this is a review by Carruthers and all looking at blindness following injections of the face. And again, this wasn't really addressing microcannulas, but it was just an awareness. And we are all now very aware of this very scary risk that can happen with injection of fillers. Next slide, please. This was actually a really important study that was published a couple of years ago. So you can see that 370 dermatologists were queried, and they looked at 1.7 million injections. And they estimated that the rate of a vascular occlusion was 1 in 6,000 with needles, and it was only 1 in, where's the number there? 40,000, almost 41,000 with a cannula. So you can see that the rate of vascular occlusion with a needle versus cannula, I mean, is just magnitudes of difference there. So that really, I think, kind of shows and is pretty strong evidence towards the safety of a microcannula with fillers compared to a needle. Next slide, please. This is a study that I published along with some of my colleagues several years ago. We looked at the nasolabial folds, we looked at lips and other areas, but just to show you the difference in bruising rates. So here we looked at Juvederm Ultra and Restylane, and I think I looked at 1,000 patients that I had injected, and you can see that the needle bruising rates with both approached 60%, whereas with the cannula, they were 2% and 2.8% respectively with the cannula use. Next slide, please. This is another study looking at microcannulas. And really the point of this is to show you how much data there is on microcannula use. Microcannulas now are really, in my opinion, the standard of care. And that's why a lot of companies, when they're releasing fillers and products, they are including the microcannula use for them. Next slide, please. So this is just showing, this is an older slide looking at a typical needle injection. Sometimes you won't even see the bruise when you're done. You'll do the injections, you'll hold pressure, you'll walk out the room, and then the patients are sending these pictures by email or by text to your staff, and it can be quite embarrassing for these patients. Next slide, please. So again, I want to be fair that cannulas can cause vascular occlusion. There have been a handful of cases of blindness, particularly in the forehead and in the temple when utilizing a microcannula. So it's not to say that a cannula can't cause vascular occlusion or blindness. It's just far less likely. And as I said earlier in the webinar, the smaller your microcannula, so a 27 gauge, the more likely you will be to penetrate a vessel wall compared to, let's say, a 22 gauge. Next slide, please. This is just showing, again, the mechanism of blindness. Our external and internal carotid systems have a lot of overlap, and that's why the nose and kind of central perinasal glabellar region have such a much higher likelihood of causing an issue, particularly with a needle, because you have a lot of connections with the internal carotid system, the ophthalmic, central retinal arteries to cause either blindness, ophthalmoplegia, diplopia, etc. I did hear recently at the UCLA orbital and oculofacial plastics course that it takes a double, and this is a theory, so it takes a double hit to create blindness. What does that mean? So we have, let's say, a 1 in, if you look at the study, 1 in 5,000 chance of getting a vascular occlusion with a needle. But certain people have some retrograde flow from their external carotids to their internal carotids. So it has to be in one of those individuals where it will cause the embolus to go retrograde into their internal carotid system. And so we have a lot of vascular occlusion. We've all seen the ugly, scary photos, but and some patients are like, wow, I'm so surprised, or thank God they didn't go blind. Why not? Because they probably had strong flow away from the internal carotid system in those watershed areas. And I think every year we're finding out more and more about the mechanism of vascular occlusion, the mechanism of blindness. And these are all things that, at these conferences that we go to, we hear from these brilliant minds and academic research areas to really understand, A, how to prevent this, and B, how do we treat this if it were to happen? Next slide, please. This is a typical appearance of the vascular occlusion. This is pending necrosis. You can see that the area injected here with the needle in the nasolabial fold is pending necrosis. So this is something that would require immediate attention with hyaluronidase. The latest research now is showing ultrasound guidance of injecting hyaluronidase into the SMAS, into the near or into the vessels, and then into the affected area. Currently, our ACE protocol talks about every 15-minute injections. Leonie Schelke and the Erasmus group out of Amsterdam and others now are looking at more targeted addressing of the area with smaller amounts of hyaluronidase, so that we're not just blindly flooding the area with hyaluronidase. And more of that is coming out. We're going to talk a lot about that at the upcoming LAMCA meeting in March here in Beverly Hills. Next slide, please. This is again showing the kind of the scary area, which is the nose and the perinasal region. And there's just no way to predict anatomy when we're doing injections. Most of us are doing injections blindly, quote unquote. And this is the typical pattern we think of, but sometimes there's a nice, I do rhinoplasty every week. Sometimes I see a vessel right in the middle of the nose where we're taught that it's safe or safer to inject. Next slide, please. So now let's go through each of the different areas and talk about best techniques. And I have little videos to show you guys. One of my favorite areas to treat is in the interfascial space. So this is between the superficial temporal fascia and the deep temporal fascia. So it's on the DTF, but I almost always compound it with injection into the retroorbicularis oculi fat pad, or the tail of the brow. And I also want to review infraorbital hollow techniques. So next slide, please. So let's look first at the temple and tail of brow. Next slide, please. So here you can see the pilot is with a 23 gauge hypodermic needle. In this instance, I'm using RHA3 to fill the interfascial space. This is a 25 gauge, 1.5 inch DermaSculpt cannula. Notice how I'm twisting, popping through the superficial temporal fascia. You have to feel that double pop, and then you feel that grit of the deep temporal fascia, and then it slides very easily. Also, I'll pick up the tissue to make sure that my cannula, if I back up and I lose the plane, that I'm constantly on that nice gritty plane. That will keep you deep to the superficial temporal artery, and that'll allow you to transition from the DTF onto the periosteum of the tail of brow, so that you can do safe and nice tail of brow injections to raise a brow. Here you have to be careful of the sentinel vein. You can typically see a little blue dot. That vein, the zygomaticotemporal vein, comes through all the fascias. So be careful as you're going with your cannula just to prevent bruising. But you can inject the entire non-hair-bearing temple, and you can even go to the hair-bearing temple. I will warn you that the hair-bearing temple is more sensitive, and so you have to be a little bit careful. There you can see her treated right side. You can see the big scalloped temple hollow on the left side with nice interfascial temporal injections. Now, it's not to say you can't use a needle on bone as well, and very often I'll teach or show the sandwich technique of needle on bone with the temple and then interfascial. Today's webinar is focusing on cannula injections, so I will be just showing those techniques. Next slide, please. And here you can see the typical treatment. I only had to use a little less than half a syringe. We just happen to use RHA3, but a lot of products are great here in the interfascial space to volumize. You can see the tail of the brow looks volumized. The skin looks better, and it just looks a little bit more hydrated. Next slide, please. That's the entry point. Next slide, please. Okay, there you can see the other side as well. All right, and then this is a video that just shows the smooth transition. Look at her temporal scalloping there, the hollows. And then you'll see after just a much smoother transition of the forehead to the temporal region. Okay, we can go to the next slide. Okay, so now let's look at tear troughs and infraorbital hollows. We actually have, so currently there are no FDA-approved indicated fillers for the temples. That's going to change soon. But in the IOH and the infraorbital hollows, we do have 2 fillers that are now FDA on label. We have Juvederm Volbella, which was the very first indicated filler, and now we have Restylane Enlight. Okay, so this is showing Restylane Enlight in the infraorbital hollow. So we can go. Now she had a thread lift, so that's why she's got, bleeding from the side of her face there. So try not to pay attention to that. She had actually a lot done, as I'll show you in her before and afters. We had lifted her cheeks with the threads. Now I'm using the Restylane Enlight, which is the newest filler. And in the infraorbital hollow, when I use Restylane Enlight or Juvederm Volbella, I like a 27 gauge 1.5-inch cannula. Why? Because it doesn't allow me to push too much product at once. And so this is kind of the preferred technique that I use. I use a cannula. I'm in the suborbicularis oculi fat compartment, and I'm putting my left finger, my non-injecting finger, on the orbital rim so that my cannula doesn't pass that point. Notice how much cheek she has under my cannula. So I get deep fairly quickly with the cannula, and then I just kind of ride along the rim and put little depots of a product along the infraorbital hollow. And typically it doesn't take more than 0.2 or 0.3 cc's. Restylane Enlight is only 0.55 cc's, but even if you're using this, Juvederm Volbella, or off-label, if you use things like RHA Redensity or whatever filler it is that you like, or PRF or Easy Gel, this is the technique that I like to use. You're staying nice and deep, and this can be intimidating for those of you that are just starting out, because you can't see the track of the cannula. You just feel the tip of the cannula under your fingers. The biggest advice that I'll give you if you're doing tear troughs or infraorbital hollows with a cannula is that when you enter with your cannula, you can play the video again, please. Go back and play this video again. When you enter with your cannula, try to get deep right away, okay? So don't come too close to where you're trying to inject the product, because then product can track back and it's going to be harder to get into the deeper plane. So my injection port, you can see, is kind of right on the head of the zygoma, and then I dive right away with my cannula, and as soon as I feel myself in the deeper plane, then I'm going to slide along the periosteum, put my finger as a stop gap to make sure I don't pass the orbital rim, and I'm really injecting just below or on the orbital retaining ligament into the deep SUF compartment. So I'm eliminating or minimizing any injection of filler into the malar bag, and I'm also minimizing any injection past the orbital rim into the actual orbit itself, and I'm minimizing any injection of a hyaluronic acid filler into the orbicularis muscle. All of those things can lead to puffiness, edema, and a problem later on. You may not see it for a week, 2 weeks, you might not see it for months. But if you utilize this technique and really get deep right away with your 27 gauge cannula, you're going to really have very minimal problems with your products. Of course, assuming you've selected the right patient to inject the HA into. If a patient is not a good candidate for hyaluronic acid fillers for whatever reason, they're too deplete, then you can use Easy Gel in this area with this same technique. Next slide, please. So this patient, so she had more than eyelight to her under eyes. You can see the full treatment that actually Francine and I performed for her for one of our YK Advanced Aesthetics training videos. We did a thread lift for her nasolabial folds, but we did do eyelight to her under eyes. You can see I used a 27 gauge, as you saw in the video. We did a lift to her temple. I actually elected to use a needle deep on her. We did define to her piriformis, define to her chin. She did have Volbella injected to her lips with a cannula. You'll see a video of that later. And then we did a 1-to-1 blending of define with Easy PRF for the corner of her mouth. And then we did Botox cosmetic in her upper third for her glabella, forehead, and lateral canthal lines. Next slide, please. But look at her under eyes. I mean, it's a less is more approach. I mean, I use 0.25 cc's per side, and you just want to blend that lid cheek junction. That's really what it's all about. And I always tell my patients when they come back, like, oh, I still see a little hollow there, have them smile. And then I tell them, like, you need a little space for your cheeks to go into that area. If it looks perfectly corrected at rest, then potentially when they smile, you'll see some puffiness under their eyes, and that's a bad look. That becomes that filler face look. It's one of only a couple things that can lead to quote unquote filler face. So the under eyes and the lid cheek junction is really a key area to get right. Next slide, please. Here again, you can see the shadow of the under eye looks much better. Now, of course, everything looks better because she had thread lift, she had the corner of her mouth, but that's really the key. And her temples look better as well from the deep lift injections. Next slide, please. Okay, so let's go to the midface. Now, the midface is where is a really good training grounds for a microcannula. And I've done lots of trainings both myself, also in partnership with the Allergan and with Galderma, and now Revance actually, RHA4, you may or may not have heard, is indicated with a cannula as well. So let's go through mid-face injections. Okay, so this is a model here. So I'm planning out the area. This is Juvederm voluma, and I'm just showing the trajectory that we want to go. You draw a line from the lateral orbital rim, connect it to the alar facial crease, and that's going to be your insertion. Now, aseptic technique, I'm rubbing with hypochlorous, 23 gauge hypodermic needle. Okay, and then when you take the hypodermic out, you want to go in at the same angle as the needle. And notice how I'm picking up the cheek and I'm immediately going under all of that tissue. So you want to be pretty much on the periosteum without hitting the periosteum. But when you're utilizing this in this glide plane, it's just such a beautiful plane deep on the bone there. So you can do your lateral cheek this way. Then now you can see me moving around and doing a little bit on the head of the zygoma. And then the last thing I do is I'll inject deep below the tear trough in the medial deep cheek fat pad for anyone that has deficiency hair. And this to me is a cannula only zone. So you can, on label, we have voluma there, we have contour, you can do lift. Now we can do RHA4, but this area, notice how I'm picking up the cheek and just slowly advancing. Okay, so look at how much tissue there is above my cannula. This can be intimidating when you first start, but that's the best place. And you want to put very little in this medial area. And remember, you need space for them to smile. And so that's a real key consideration. Next slide, please. So this is that patient that we were treating, and you can see I used 1 cc of Juvederm voluma in each of her midface, and then I actually did a Volbella to her infraorbital hollow, and we did 0.5 cc's. So I used a 25 gauge cannula for the voluma. Again, 25 gauge 1.5 inch is my workhorse. That's what I use for most products in most areas. In the infraorbital hollow, I will use a 27 gauge 1.5 inch because again, Volbella, especially Volbella, is so easy to inject through a 25 gauge. I almost feel like it comes too fast. And then we did Volure with a cannula to her corner of the mouth. And then I actually used Volux, both needle and cannula, to give her a better jawline shape. And I usually will do like 0.5 cc of Volux to each gonial angle. And then I'll do 0.5 cc of Volux with a cannula over the antagonial notch, which is the danger zone. Next slide, please. Next slide, please. Great. So let's go now to mid-face, but with focus on buccal hollows. Okay. And this is one of my favorite ways to use a cannula for someone that has panfacial volume loss. Okay, play the video, please. So this gentleman, as you'll see in his before and afters, has really global panfacial volume loss. Hadn't really had any injections before. I think we ended up doing like 8 syringes on him. You can see his buccal hollow there. Here I'm utilizing RHA4, and you can just pick up the tissues and kind of go all around with the cannula. So I love this because it's an artistic way to inject. We're not just sticking needles, injecting, massaging, and hoping for the best. We're literally painting, we're sculpting. This is why we call it the skin sculpting technique. And I always am pinching the tissue so I don't get too superficial with my product. In the buccal hollow, yes, it's going to be subcutaneous, but I don't want it to be too close to the skin. So these are going to be sub-Q injections, and then higher up, kind of closer to the prezygomatic space, they're going to be a little bit deeper. But this is a beautiful way to fill buccal hollows, as you can see here. And I'm countertracting so that my cannula moves forward, and then I inject retrograde. And I kind of come all around like a fan in these areas. And you can do this atraumatically, and so you're not causing a ton of bruising. Now, you will cause some swelling in this area, but that's okay. And that swelling goes down pretty quickly. So this is actually one of my favorite things to do with a cannula, which I just don't even know how to do with a needle without causing so much bruising and trauma that I have to stop the treatments. Next slide, please. So this gentleman we treated with all RHA, so 2, 4, 6, 8 cc. So we did RHA4 for his midface, we did RHA3 for the buccal hollows, and then RHA2 at the time. Today I would use RHA Redensity, but it wasn't out then. We did for the infraorbital hollows. The red dots are my midface injection ports that you saw in that last video. The blue dots are were my entry points for the infraorbital hollows. Okay, so this was 2 weeks after his treatment. Look at the buccal hollow, how much better that is. The right side was actually a lot more hollow than the left side, so we did have to put almost 2 syringes of RHA3 into that big buccal depression. Next slide, please. Then he came back for a retreatment at 6 months, and we did his temples, which we hadn't done before. So I did some deep temple injections with RHA4, and then I did a little bit of a touch up to RHA3, and now this is his 16-month result after all those injections. And so that was my entry point for the temples, and I used the same entry point for RHA3 in his mid-face tune-up. Next slide, please. And you can see how well that has held up in his mid-face and his under eyes. So that just again shows you, especially with the cannula, when you're putting little bits in a lot of different areas, I think it sculpts the face really nicely. Next slide, please. Let's look at the chin. So I love injecting chins with a cannula. Now this patient, you can see a bunch of threads coming out. So I had done the threads. Now she had a weak chin. So I'm using a 22 gauge cannula here. You can also use a 23 or a 25. I'm using Restylane Define, which actually is a little bit hard to push through a 25 gauge cannula. So I find that a 23 or a 22 works really, really well. Here I'm talking about going deep. Okay, so you want to pick up the tissue and then go behind, deep to the mentalis, into the deep chin fat pad. And that way you can inject nice and deep, you can project the chin out, and if someone has prejowl sulcus hollows, you can also fill along the prejowl sulcus. So you do have to be careful with this in terms of pain, because the patients, you have to go through the depressors to get to the deep compartment. And so you got to kind of do that quickly to minimize the pain. I have been playing around with an injection point under the chin. You do have to be careful though, because it's very close to where you want to inject. If you inject too high, you'll inject and you'll see it in the gingival sulcus, and you don't want to do that. And you certainly don't want to enter someone's mouth. It does hurt a lot less when you come under the chin, but your cannula is going to be mainly exposed. It has to be just a couple of centimeters of the cannula being in the central portion of the chin. So you can come from under the chin if you just want to project the chin. And if you just want to come from the sides, you can do that as well. And you have to really pick up the tissue, go through the depressors, and then feel that nice smooth plane. There shouldn't be any resistance there when you're injecting the cannula. Next slide, please. This is just showing what you can do with a cannula. Now, again, I think chins are very underreported in terms of vascular occlusions with needles. The submental artery, or the ascending mental artery, which is technically what it's called, which is a branch of the facial artery and has connections to the lingual, is typically about 6 millimeters from the midline. But it runs fairly close to the bone, and the muscle also is it's a big fan muscle that comes to the skin, which is why you see mentalis strain or peau d'orange. So I think we're going to see a lot more VOs with a needle in the chin, which is again why I think the microcannula can make a lot of sense. And this is just 2 cc's of Define to the chin with a cannula. Next slide, please. So this is now getting into lips. This is an old slide. This is from Galderma looking at silk to the lips. Now you can come from the commissure, but you have to be really, really good about your cannula being superficial here. The biggest problem I see with the lips, and people say, oh, I had to use more product or it wasn't as accurate, is that their cannulas are deep. It's in the fat or in the muscle. So you want to get your cannula immediately submucosal as soon as you get in here. And sometimes coming from the commissure is not the easiest way to do that. So sometimes I'll actually come from the vermilion border a few millimeters from the commissure so I can pinch the lip and get immediately, you should see the outline of your cannula. Just opposite of what I told you, the mid-face and under eyes. In the lips, you need to be submucosal as much as possible. Next slide, please. Next slide, please. Okay, so this is a video technique. So this is Volbella to the lips. And here I'll usually start with the vermilion border. Okay, so this is, you can see the 27 gauge cannula. Look how superficial it is. Okay, and we're tenting out the lip, and it's just immediately submucosal. So you can come to the central midline of the lip and then inject retrograde. And then if you want to inject the body of the lip, you can come and inject the body of the lip as well. Now, I know a lot of you are fanatics with the needle in the lip. But again, a cannula, in my opinion, can be used for really nice injections of the lips. And again, if you stay immediately submucosal and feel and see your cannula as it's traveling under the lip, you can do really nice and accurate lip injections. Okay. So this is again showing that same patient, and you can see with 1 cc of Volbella how the lips are nicely hydrated. Okay, now the nose. I always caution on injecting the nose, and a lot of you don't inject noses, and especially if a patient's had a rhinoplasty, I would not inject their nose at all, needle or a cannula. I would just stay away, okay? But for some patients that, especially if they're lacking a bridge or they're lacking tip support, and we are developing threads through Nova Threads for the nose as well, but for people that are candidates for a liquid rhinoplasty, these are the kind of 2 ports of entry. A lot of times we'll just use the 1 port at the tip. And if you have the next slide, please, I can show you the technique here. Next slide, please. So this is actually happening. You'd be using Easy Gel on this patient. So you can see my port. I'm using a 25 gauge cannula. The key here is to pick up the nasal SMAS and glide along the cartilage and the supraperiosteal plane, because the SMAS is where all the vessels are. And so here you can see I'm all the way at the top of the bridge. I am constantly moving my cannula as well, but just in the central midline area. And I'm constantly using my non-injecting finger to pick up the SMAS, because when I travel forward, I want to make sure that my cannula is not poking into the SMAS or into the vessels, okay? So that's for the bridge. And then the video, I think, keeps going to show the columella. So here I'm coming down through the medial crura, which are the 2 cartilages here, coming down to the nasal spine and injecting all the way up. Now, I happen to be using Easy Gel on her, but most patients you would want to use a higher G prime filler if you wanted something to really hold the nose. So Juvederm Voluma works really well. Restylane Lift, RHA4, and even Juvederm Volux I think would work really well here. But you have to be really good with your injections and not have it into the muscle. This is a patient that I injected. She's dying to have a rhinoplasty, but she hasn't been able to convince her husband yet. And so we did a little bit, like almost a cc of lift for her supra. As you can see her supra tip there, and look at her tip being lifted there. Look at how her nostril kind of goes down in the before. And you can see how her tip is a little bit lifted. Again, it's not a rhinoplasty result, but for some patients, this can actually be very, very gratifying and lead to happiness. So that's all I have in terms of the specific areas and techniques. I do want to open up the floor for Q&A. I'm sure you guys have a lot of questions, hopefully, so that I can answer your questions, help you troubleshoot, and we'll do that for about the next 10, 15 minutes or so. So, hey, Bonnie. I am putting also the registration link for the LEMCA meeting. We're going to have a lot of live demonstration injections with needle, cannula, threads, all the things, just like we did last year. And we'll also have really good didactics kind of talking about all things with aesthetics. So the question is, do you also like to augment from the aspect of preauricular to pull back as well as mid-facial anterior volume? Sorry, Bonnie, can you clarify your question? Okay, other question is, can Easy Gel be injected superficially in the tear trough area? So it can, and you won't get that prolonged edema, but that patient, if you inject Easy Gel superficially, like let's say you do the deep injection, but you want to come superficially as well, the patient will have swelling under their eyes for 1 week or even 2. So you have to be careful in terms of framing the proper healing expectation for the patient if you come superficially with Easy Gel. So Cindy Fair says, I thought a 27 gauge needle was as sharp as a needle. It's not. The 27 gauge needle is sharper than a 25 gauge, but it's certainly not as sharp as a 27 gauge needle. So there was a really good study looking at blepharoplasty numbing with a 27 gauge cannula versus a 27 gauge needle, and the bruising. And I actually use a cannula to even inject my blepharoplasties because it's a skin excision most of the time. So there is, it is not as sharp as a 27 gauge needle. Question is, when you're using a cannula, how can you tell if you're in the right plane? So there's a couple of tricks. So when you are in, let's say, the lateral midface, if you can feel the cannula, then you're too superficial. If you're on the bone and then you pick up the tissue and move the tissue, that means you're deep to the SMAS and you're in the right plane. The other hints are that if your patient is like getting tortured by your injection, you're probably in the SMAS, because that's where, you know, the muscles are, and that's where it's going to be the most sensate. So if the patient's like, yeah, I feel a little pressure, I don't really feel it, then that's typically the right plane, because you're going to be either deep to the SMAS or superficial to the SMAS. In the chin, you know, when you come with your cannula in the chin, I do the little wiggle test, and then I don't feel my cannula in my fingers, and my cannula doesn't move when I'm moving the chin. So that tells me that I'm also in the right plane. Okay, tips to change directions with the cannula. This is a really good question. So when you want to change direction with a cannula, you should never see your cannula bending. If your cannula is bending, that means mentally you're not where you think you are. So you need to pull out the cannula almost all the way, redirect. The shaft of your cannula should always be straight. That's a very important principle of microcannulas. When you pull the cannula out, you'll feel the tissue kind of untwisting from it, and then you can change directions. And then it's always like a twist and a push, twist and a push, and that's how you can get the cannula to travel through the tissues really nicely and really well. Let's see. In the hairline, yes, you can use a cannula to go again into the hair-bearing scalp. It is sensitive, and you need to make sure that you're on that deep temporal fascia, so you minimize any chance of injecting into the superficial temporal artery. Let's see. Are you injecting Redensity deep in the IOH? Yes. So Redensity or RHA1 is one of the products that I like for the deep IOH. I use a 27 gauge, 1.5 inch cannula for that. For the chin, there's a lot of products that are great. Lift works well. Voluma is, I mean, it's one of my go-tos for the chin, and RHA4 works really well in the deep chin as well. Yes, Easy Gel is autologous platelet gel. Microcannula for Sculptra. So let's talk about Sculptra, because I kind of glazed over it. So I actually love using the 23 gauge 2-inch cannula, the DermaSculpt Microcannula for Sculptra. And we actually kind of designed this 23 gauge for these thicker injections and for Sculptra several years ago as Sculptra injections got more popular. I like to inject with my entry point, basically in the central cheek, and then I'll do some deep Sculptra injections along the bone, and then I can do some medial cheek injections, preauricular. I can come down more superficially to the corner of the mouth, and I can even go deeper into the piriformis. So I can do all the on-label Sculptra injections with a cannula. Of course, using a cannula is not on label, but you can do all this. You can do deep injections, you can do superficial injections, and the Sculptra injections are quite beautiful. I will use cannula also in the temple. I do like sandwiching Sculptra in the temple, meaning doing some needle deep on the bone and then some interfascially to get that connection from the temple to the forehead. So I like using the sandwich techniques for the Sculptra as well. Preventing Tyndall effect is really just about deep injections and picking the right patient. If someone has paper thin skin and they're fair and they have no fat, then really want to consider Easy Gel injections or a blend of Easy PRF with a hyaluronic acid filler, 1-to-1 blend, so equal parts. Have them come back at 6 weeks for an additional enhancement. Yes, RHA4 actually has a cannula indication now for the midface, and that gentleman that I showed you had RHA4 injected. Slight one out. Risk of occlusion with PRF. So I get this question all the time. We launched EasyPRF in 2016, and to date, we have not a single case of necrosis. I've heard of a couple of cases of a temporary vascular occlusion that the practitioner was able to see right there on the table, but it self-resolved with gentle massage and compress within minutes. So there's something about 100% autologous PRF and presumably easy gel, because again, it's still 100% autologous, that does not lead to this cascade of vascular occlusion leading to necrosis. Part of it, of course, is that the hyaluronic acid, or PLLA, is inflammatory. So if you're injecting filler, like a synthetic filler, or biostimulators, which is also synthetic, into a vessel, you're going to have some inflammation and spasm. So I think that element of it doesn't exist with PRF and Easy Gel, which is why we've never seen a case of necrosis with pure Easy Gel or pure Easy PRF. Okay, wow, great questions, guys. Nasolabial fold used to be #1 injection site. What size cannula and technique do you use for nasolabial fold? Okay, so let's talk about the nasolabial folds, because it's still an area that needs to be addressed. Now, nasolabial folds, we now understand to include filling the prezygomatic space and the deep piriform. So my algorithm to the nasolabial fold is first see if there's any hollow or deficiency in the premaxillary prezygomatic space. Address that first. Then, if they're older or even younger, if they have bone loss, come to the piriformis, and I use the same injection port. One port here to do the zygomatic space, and then this port I'll come right under the nasolabial fold with my cannula, 25 gauge, 1.5 inch, and then inject into rhistose space or the deep piriform space. Last thing that I'll do is I'll see if they have any superficial hollows. Then I'll pull my cannula back and then come sub-Q. So now when my first injection deep is going to be deep to the angular artery. Then when I come back and come subcutaneously, it's going to be superficial to the angular artery, and then I can finish the job with very small amounts of filler. You don't want to depend on the superficial compartment here, because the filler will get into the elevators of the smile, and then you'll get limitation of the smile. So you want to really focus on deep piriform injections, prezygomatic injections, and then you can finish the job with like 0.2 or 0.3 along the nasolabial fold, all with a 25 gauge, 1.5 inch cannula when you're doing that. The introducer needle. So the introducer needle depends on where you're injecting. When I'm injecting in the midface, it's 90 degrees because I want my cannula to be able to go medially, centrally, and laterally. Same with the infraorbital hollow, because I'm usually doing the whole circle. When I do the chin, I actually will come in at an angle because I want to miss this vessel that we always see, kind of branches of the facial vein that come up. And I look for those vessels to minimize bruising. That one I'll come in at an angle because my cannula is going to be at an angle. Same with the temples. I don't come 90 degrees because I know my cannula needs to be at an angle to penetrate the superficial temporal fascia to get onto the deep temporal fascia. So in summary, the angle of the needle should be how you want your cannula to go. If you come in at an angle and then you're trying to change directions, because you've created a hole through the dermis at your angle, it's going to be harder to change directions. So if you're going to come in at an angle, you really need to be kind of committed to that angle for the injections. Okay. Sorry for the lighting changes, guys. We just want to be a little dramatic here. How deep do you start your needle port when you want your cannula to go to bone? So that's actually a really good question. I don't think that you need to hub your needle to the bone. The cannula, you need to guide it to the bone. Because if you hub your needle, there's no way you're going to go through the same hole with your cannula. It makes no sense to try to do that. And so your cannula is what's guiding you to the bone, not the hub. Is it true in place deep dermis, you have a higher chance of migration? So first of all, I don't think you can inject filler with a cannula into the deep dermis. If you're going to inject into the deep dermis, it's going to need to be with a needle because the cannula is too blunt. Maybe with a 30 gauge, but at that point, what's the point? Migration, I believe, happens when there's a lot of injection done into the superficial compartment. So the superficial compartment is the compartment that moves and slides over our SMAS. So that's the one that can lead to migration. So you have to be careful with how much you're doing into the superficial compartment. 1 to 2 hyperdilute for Radius. I think that's great. You have to be really comfortable with Radius, and you want to stay deep with Radius when you're doing it. I actually will combine it with Easy PRF, and I do the same thing with Sculptra as well. Best technique to get the cannula through the entry hole, pinching. Yes. So when you make your port through a cheek or wherever you want to pinch the cheek and then just quickly go through your hypodermic through the skin, but you want it to go through the dermis, but you don't want it to go too deep. Then usually I'll hold the cheek pinched. My assistant will pull out the needle. If you inject unassisted, you're going to use your other hand, keep the cheek pinched, take it out with your hand that has your syringe in it, take the needle out, put it on the tray, try not to lose sight of the hole, then come holding your cannula, holding it like a pen, and then, or a dart, and then injecting or pushing it through the port. Once you're through the port, you can kind of let go and then hold the syringe how you want to inject. But initially, you always want to hold it closer to the hub. Otherwise, you're going to be struggling to get the cannula through the hole. And then when you're traveling through the tissues, I also will hold it closer to the hub and kind of, make little back and forth circle motions with my fingers so that I'm traveling through the hub. Okay, I already answered VO with PRF question. Can you use Excel deeply for volume replacement? I'm not sure what Excel is. So Revance initially taught RHA subdermal superficial, but now with the cannula indication, I think most people are doing deeper injections. Okay, so I'm going to take a few more questions here. So threads and fillers in the same area. So when I do a thread lift, I'm typically putting lidocaine into this area, and then I'm lifting the threads. I don't like putting fillers the same day because it's really hard for me to accurately tell how much volume they need. Plus, the thread lift brings up the cheek pad and helps volumize this area. So answering your question, Guillermo, I actually like to wait 4 to 6 weeks even after the thread lift to see what fillers are needed in the mid phase. But I will do under eye filler at the same time, like I showed you in my patient. I'll do temple filler, I'll do chin, I'll do almost everything else. So threads, I think, are to kind of pick up the cheeks, pick up the jowls. And then the fillers, I think, are for the central face. So under eyes, piriformis, chins, and of course you could do lips if you wanted to. Hyperdilute radius with a cannula. I would use a 22 gauge. When I do it in the neck, I use the long 22 gauge. It's 2 3/4 inches. I do a very much diluted radius, so I don't do 1 to 2 or 1 to 3. It's like 1 to 8. So there's a lot of saline and PRF in my radius to really utilize it as a biostimulator. Easy gel, I actually like injecting through a 25 gauge 1.5 inch cannula. I've been heating my Easy gel a little bit longer, 12 to 14 minutes, because I want it to be thicker. I want it to feel like a filler when I'm injecting. Oh, Easy gel deep for volume replacement. You can, but you can't think of Easy gel like one of these high G prime fillers. So if someone really needs a lot of deep volumization, you may want to consider just a deep hyaluronic acid filler or blending it 1-to-1. Don't be afraid to tell your patient, let's do this in 2 phases. We'll blend your Voluma, or we'll blend your RHA4, your lift, or whatever you want to use 1-to-1 with PRF, so you get the benefits of PRF, and then you come back when we do a second round. If you have the all-natural patient or the patient that has a contraindication to hyaluronic acid fillers, then yes, you can use the Easy gel, but you have to kind of set proper expectations that they're not going to necessarily have a 1 to 2 year result with just Easy gel. Do all offices provide these services using a microcannula? So as I said in the beginning, 70 to 90% of us are now picking up a microcannula for some area. No one is using a microcannula for every area. I don't even use a microcannula for every area. I mean, when you're going on the gonial angle, when you're going deep on the temple, you have to use a needle, in my opinion. But for foreheads, under eyes, cheeks, piriformis, lips, chins, and certain, antigonial jawline, sculptra, preauricular, I'm using a cannula for all of that. And hands, I didn't mention in the webinar, but 2 injection ports, Lido with epi, the long 22 gauge cannula with the hand. My favorite hand concoction, and you're gonna love this, is 1-to-1 Easy PRF with Juvederm Ultra. It is freaking phenomenal. I usually will do like 2 syringes of Juvie Ultra with 2 syringes of Easy PRF. So I have 4 cc's per hand, and it is like one of my favorite long-lasting, beautiful back of the hand results. Yes, the angle of the cannula. Okay, so this will be I'll take like 2 or 3 more questions. The angle of the cannula when injecting the chin. Okay, so this is important. The cannula, the needle, I will, again, if I want to inject just the chin, I'll look for those 2 kind of veins here. And I'll come in at like a 30 or 45 degree with my needle. And I'm usually using a 25 gauge 1.5 inch cannula, just through the skin, barely through the skin. You don't want to go too deep because you don't want to cause a bruise there. Then, as soon as I put my cannula in, I feel 1 pop. That 1 pop is through the dermis. Then I'll pick up the chin and twist the cannula, 2nd pop. 2nd pop now is through my SMAS. The SMAS here is going to be either your depressor labii inferioris muscle or your depressor anguli oris muscle, depending on whether you're here or here. That's the 2nd pop. Then as I travel through my cannula parallel to the bone, as I'm picking up the chin, now I'm super periosteal, deep to the mentalis, and I can just move my cannula very gently and slightly while injecting the deep chin fat pad, and it projects the chin so beautifully. It's really, really nice. Piriform with the microcannula takes a little bit of practice. So again, I make my port typically just lateral to the nasolabial fold, and I do 1 pop. That's the first through the dermis. 2nd pop is going to be through the SMAS. The SMAS here, again, the SMAS is just your muscle layer. This is going to be either your levator anguli oris, or it could be your LLSAN, your levator labii superioris aliquinasi, again, depending on how close you are to the piriform. And then you'll feel it fall right into the kind of deep piriform space. You shouldn't be able to see your cannula. And then I always do little micro movements of my microcannula, just barely, because I do like moving with my injections, but you can do a bolus. Again, it's very, very safe. And the chance of penetrating a vessel with a microcannula, as you've seen with the data and as I've shared with you, is much, much lower. Okay, I think I'm going to end with that. My Instagram is at Dr. Kian, which you probably already have. If you have any other questions, feel free to send me a DM, and I'll get back to you as soon as I can. The upcoming LAMCA meeting, March 21st to the 24th here in Beverly Hills, California. I'm bringing the best and the brightest from around the country and even international to talk about all things aesthetics. I hope to see you all there. If you haven't been there before, I'll put the link to the meeting again. Thank you, Janice. Thank you. Thank you all so much. I really appreciate your time and attention on a Monday evening, and I look forward to seeing you all soon.